Hi, my name is Chris Sutton. I'm going to be doing my malignant hyperthermia video number 4. I'm first going to do my machine check. I'm going to check my pipeline pressure, make sure there's no crossover, make sure my pipeline pressure is at least 50 psi. And I'm also going to check my E-tanks, make sure my key available and they're at least halfway full. Looks like we're good there. I'm going to make sure I have my AMBU bag and my suction available. I'm going to connect to my suction, make sure that's working. It's working just fine. Now I'm going to make sure I have my extra airway equipment available, as well as my rescue meds, but I'm gonna use my Apple, so my sucks will not be available for this case, since we're doing an MH case. I'm gonna check my flow meters, my Link 25, make sure they're functioning appropriately. I'm also gonna perform my low pressure check, make sure there's no leak in my flow meters, nor in my vaporizers. I'm also gonna make sure that my vaporizers are full. That's what I usually do, but for this case, we won't have vaporizers available. I'm going to try to make sure I have my AC power. I'm going to calibrate my O2 sensor, make sure my CO2 isn't exhausted. My CO2 isn't exhausted or desiccated. I'm also going to check my monitors, my ventilator settings, make sure they're appropriate for this case. And I'm going to check my inspiratory and expiratory valves. And then I'm going to go ahead and do my high pressure check. I'm going to include my white piece, make sure I'm on manual mode, and then turn my PL valve all the way off, and then push my O2 flush to about 30 centimeters of water, and then make sure that holds for at least 10 seconds. That's adequate. Okay, because this is an MH case, I'm going to go ahead and remove my vaporizers. And after I've done that, I'm going to go ahead and flush my machine using 10 liters per minute of O2 for at least 20 minutes. Some machines may take up to 90 minutes. I'm going to keep the gas flow at 10 liters per minute, prevent a rebound phenomenon. I'm also going to replace my old breathing circuit with a new breathing circuit, and then I'm going to change my CO2 canisters just to fresh absorbers. Okay, my CO2 canisters have been replaced. Depending on the facility, I'm going to have charcoal filters to filter anesthetic gases from the system. Okay, we're on to our patient. We're prepped for an MH case. I've prepped my machine. Okay, we have a 45-year-old female who has a BMI of 29. This is based off of 167 centimeters and 82 kilograms weight. And our patient is coming from the ED for cholecystitis to have a cholecystectomy. She has a history of type 2 diabetes, hyperlipidemia, TKA, hypertension, GERD, overweight, and malignant hyperthermia. I did ask her about her current medications. She did report to me, the doctor wants me to take a bunch of things, but I can't because I don't have insurance. So we're not currently sure what medications she's taking. Labs, we took a recent CBC, CMP, blood glucose was elevated, ALT or AST was elevated, platelets showed 120, and N-nucleotidase was elevated at 27. Imaging, we did a CT that showed cholecystitis and cholelithiasis. I'm going to go ahead and ask Jane some questions. Jane Doe, do you have any medical problems? Heart, lungs, abdomen, any neurological issues? Have you had any previous surgeries? Have you had any issues with anesthesia in the past, or your family members? Have you or your family members heard of something called malignant hyperthermia or had issues with it? She reports yes to that. Do you have any known allergies? What medications are you currently taking? What did you have for breakfast? Are you able to climb up 2 flights of stairs or walk 2 blocks without feeling winded? Can you go ahead and open your mouth for me and stick out your tongue? Looks like she has a mental potty score class 1. Can you lift up your chin for me? She has a thyromental distance greater than 7 centimeters. Can you bite your upper lip? Looks like she has a class 1 for upper lip bite test. Can you open your mouth as wide as you can? I'm able to fit all 3 fingers in. And based on her observing her neck length and girth, it is within normal limits. Can you move your head side to side and up and down? That her neck range of motion is in with she has full range. I'm going to go ahead and listen to her heart and lungs. And I've determined that this patient has an ASA of 3. So Jane, the plan for this surgery is to ensure that the room is safe. We've prepped our machine and everything to make sure that it's prepared for any malignant hyperthermia cases. So we've taken any agents that could possibly trigger this malignant hyperthermia. We're also going to give some medication to make you fall asleep, and we're going to put a breathing tube down your mouth to help you breathe. And we will be using something that's called propofol. So we will use propofol for TIVA, for general anesthesia. So Jane, some of the indications for general anesthesia that is undergoing, general anesthesia is indicated for a patient that is undergoing laparoscopic surgery. So you will need to be paralyzed for this procedure. Some of the risks and benefits, Jane, the risks would be nausea, vomiting, sore throat, respiratory complications, allergic reactions, postpartum delirium, and possible triggering that malignant hyperthermia. Benefits, however, is that you will not be aware of or remember the surgery. The surgeon will be able to perform the surgery with small incisions, and your pain will be under control. Alternatives, if the doctor determined that you must have the surgery, then you must have general anesthesia. But we could potentially use a different breathing tube, such as an LMA instead of an endotracheal tube. So I have informed the patient, I have obtained consent, and the patient has signed the paperwork. We're going to go ahead and gather our equipment. In order to perform this induction, I'm going to be using a 2 Miller, but I also have a 3 Mac blade available. I also have 3 different ET tube sizes, 6.5, 7, and 7.5. I also have a stylet, emergency airway equipment. I have drawn up my induction medications and have prepared to do a TIVA for this procedure by priming my tubing for continuous propofol infusion. Okay, so for pre-induction, so Jane, after we've placed her 20 gauge IV in her left forearm, we're going to go ahead and give you some medication to help you sleep or to kind of relax you. This is called Versed. We're going to give her 20 milligrams preoperatively, and we're going to go ahead and transfer you to the OR. And then we're going to place you supine, lay you flat, and then I'm going to go ahead and place a 3 lead EKG, non-invasive blood pressure cuff, as well as pulse ox oximeter. Okay, Jane, we're going to go ahead and pre-oxygenate you with 100% O2, and we're going to do this for a couple of minutes, about 3 to 5 minutes, ensuring a tight seal. I'm going to go ahead and with my induction medication, I'm going to give her 100 mics of fentanyl, and then I'm going to give her 160 milligrams of propofol. That's based off of 2 milligrams per kilogram. And then I'm going to give her 80 milligrams of rocuronium based off of 1 milligram per kilogram. Okay, Jane, are you still awake? Jane, can you hear me? After seeing that she doesn't have any reflexes, I've checked her eyes. I'm going to go ahead and tape her eyes shut. And then we're going to go ahead and intubate our patient. I'm going to be using my stylet here, my 2 Miller. I'm going to push the epiglottis back so I can identify the vocal cords, and I can see the vocal cords. And with my size 7O ET tube with the stylet, I'm going to go ahead and insert this through the vocal cords. Maybe. That's not going in. Okay. After passing through the vocal cords, I'm going to go ahead and take out my stylet. I'm going to advance it just a little bit. Looks like we're measuring at 23. I'm going to inflate my cuff. I'm going to go ahead and tape the tube to the patient. And then I'm going to connect my patient to the breathing circuit to confirm placement. Okay. And now we're going to make sure that we have end-tidal CO2 waveforms, bilateral breath sounds, by auscultation, as well as assessing for chest raising. And then now we're going to begin the propofol continuous infusion at an initial rate of 100 to 300 micrograms per kilogram per minute. And we're going to titrate throughout the case to ensure the BIS monitor is reading 40 to 60. Okay, now we're going to talk while the patient is asleep. We're going to go ahead and talk about signs and symptoms to look out for in case malignant hyperthermia does occur. So the most sensitive indicator is end-tidal CO2 that rises out of proportion to minute ventilation. So MH can occur as late as 6 hours after exposure to a triggering agent. Early signs that we could see is tachycardia, tachypnea, masseter spasm, as well as irregular heart rhythm. Core temperature may begin to rise within 15 minutes of exposure of a triggering agent, but profound hyperthermia is typically a late sign. So if this does occur, MH does occur, our plan would be, first of all, call for help. We're gonna stop all triggering agents. We're gonna hyperventilate with 100%. And then the next thing we're gonna do after hyperventilating is we're gonna give dantrolene 2.5 milligrams per kilogram IV and get a friend to help with mixing the vials and give more as needed. We're also gonna give sodium bicarb 1 to 2 milliequivalents per kilogram, as well as glucose, insulin. We're gonna give cold fluid IV. We're gonna give cold IV fluids, cooling blanket, ice packs to axillary and groin areas to help cool down the patient. Give Lasix, Manadol, PRN to maintain urinary output of greater than 2 mils per kilogram per hour, as well as monitor for and treat tachycardia and arrhythmias. Okay, now we're at the end of the case. We're gonna go ahead and wake up our patient, turn off our propofol, and we're gonna do a deep extubation to ensure comfort of the patient, but we'll make sure the patient is within appropriate ventilator parameters. Okay, all right. Go ahead and take off the tape here. Okay, now that I've assessed that the patient has spontaneous breathing, I'm gonna go ahead and extubate. I'm gonna take off the tape, deflate the cuff, and then we're gonna suction our patient as we take it out. Perfect. Okay, now we're gonna oxygenate our patient. I'm gonna put 3 liters or 4 liters nasal cannula, and I'm gonna auscultate breath sounds. Okay. All right, now we're gonna take our patient back to the PACU, and I'm gonna give report to Nurse Daniel. Okay, Nurse Daniel, this is Jane Doe, a 45-year-old female with no known allergies, history of malignant hyperthermia, who has a medical history of type 2 diabetes, hyperlipidemia, TKA, hypertension, GERD, overweight. The surgeon did do a laparoscopic cholecystectomy. She has a 20 gauge IV in her left forearm. She was stable intraoperatively. Estimated blood loss was minimal. She received 500 mils of LR preoperatively and 500 mLs of LR intraoperatively. Was given 2 milligrams of Versed preoperatively, and then was given 4 milligrams of dexamethasone after induction, and 30 minutes prior to the end of the case was given 4 milligrams of Zofran, and then 15 milligrams of Toradol postoperatively. In the OR, her last vital signs showed blood pressure of 125/80, heart rate of 76, oxygen saturation of 98% on 4 liters nasal cannula, with a temperature of 36.5. Orders have been placed for IV fluids, PRN pain meds, early mobility, and routine post-op monitoring. What questions do you have?